All right, so the management of heart failure with reduced ejection fraction. This is probably one of the most common presentations to the hospital. Med students, interns get very familiar with the broad strokes of this. That's all I'm presenting here. I'm pretty sure it'll help you guys. And so let's dive right into it. So here we have a case where a 56-year-old man comes into the ED with a 1-week history of progressively worsening shortness of breath on exertion and now at rest. He's endorsing running out of his medications recently and using cocaine every now and then for the past month. He's also complaining of bilateral leg swelling and difficulty lying flat, requiring 3 pillows at night. So these are classic signs and symptoms of a heart failure exacerbation. We look into the past medical history. There it is, a known diagnosis of heart failure with reduced ejection fraction, an ejection fraction of 35%. We know normals upwards of 55%. And then we look at his meds, metoprolol, furosemide. These are, heart failure medications that he's supposed to be on that he hasn't been on for the past month. So all signs pointing towards a heart failure exacerbation. Let's dive right into orders. We're going to want to get a chest x-ray for this patient just to get visual evidence of pulmonary edema secondary to left-sided heart failure. We're going to also, we may require an echo. We may not, depending on how recent the last echo was. And also if something has changed in terms of the clinical presentation of this kind of heart failure. If the last echo was done very recently and we have a clear etiologic basis for this patient's current heart failure exacerbation, like the cocaine use, like the medication noncompliance or running out of medications, then it's not, we don't need a new echo. But you may want to get a POCUS, a point of care ultrasound. You do a bedside ultrasound just to evaluate grossly how the systolic function of the heart looks. And then you can also evaluate things like the IVC, the inferior vena cava, to see if it's dilated, to see if it's collapsible. Those are all things that can tell you about the fluid status of the patient. You can go ahead and get a BNP, a brain natriuretic peptide. This is basically a peptide that the ventricles and the atria are going to release when fluid overloaded. And in heart failure exacerbation patients who happen to be fluid overloaded are going to have lots of this released. So you can see this metric in maybe the hundreds to thousands when you do order it on these patients. Troponins you can get just to rule out any ACS that may be taking place. Daily weights. We want to track the effectiveness of our diuretic therapy, which we'll talk about later. But typically, you want to get these patients down to their baseline weight. When they come into the hospital, they're as a result of being fluid overloaded, they're also going to be heavier than they usually are. So you want to track their daily weights. This is typically a nursing communication order you can put in. Daily ins and outs, same thing. You want to track the effectiveness of your diuretic therapy. So we're going to be strictly monitoring the volume that they're drinking in, and then the volume that they're peeing out. And we're going to want to have that at a negative balance so that they're peeing out more than they're taking in. We can talk about that later as well. We want to put them on a low salt diet, fluid restriction, all things to counter the fluid overload. Of course, you're going to get a CBC and CMP. You pretty much get that for all your patients that come in to the hospital. With the CMP, you are tracking electrolytes, any electrolyte derangements that patients may have, especially in response to your diuretic therapy. You're also tracking things like creatinine as well, just to make sure you're not giving them an AKI, an acute kidney injury. And then a loop diuretic. This is probably the mainstay of treatment for your heart failure exacerbation. And so let's talk about that in this next slide. So in loop diuretic naive patients, you want to be cautious and start off with a lower dose of IV diuretics just to make sure that they respond appropriately to your treatment. And so you start off with furosemide 20 to 40 milligrams IV. That's equivalent to bumetanide 1 milligrams IV. That's also equivalent to torsemide 10 to 20 milligrams IV. In patients who are already on loop diuretic therapy at home, you want to make sure that their initial daily IV dose is at least 2.5 times their maintenance home dose. So if they're taking 40 milligrams orally at home, you can start with an initial dose of 40 to 100 milligrams IV and see how they respond to that. If you're not getting much of a response to that, so they're still in respiratory distress, they're still seeing significant bilateral pitting edema, then you can maybe double that dose. So if you started off at 40 milligrams IV, doubling it to 80 milligrams IV and seeing how they respond to that would be prudent. And then you can also consider nitroglycerin IV if the initial response to diuretics is not enough to alleviate the respiratory distress. I haven't seen this done in this group of patients on my wards rotation so far, but it is something that can be done. I think typically you will see, at least over the course of a few days as we're treating the patient, up titration of the loop diuretic dose to get the proper response we're looking for. But this may be, I guess, in an emergent case where you're giving them loop diuretics on that first day and they're still in significant respiratory distress. Realizing that nitroglycerin IV is something that can also be used to help decrease that preload. That's also something good to know. And so you want to diurese these patients with a net goal of negative 1.5 to negative 2.5 liters, right? So this is where you are making sure that they're peeing out a lot more than they are taking in to help resolve that fluid overload. And this is a daily net goal. You also want to diurese these patients until you're starting to see their pitting edema, their respiratory crackles, their JVD, their jugular venous distension kind of resolve. And then you're also checking your daily chemistries, like I said, to make sure your electrolytes are within normal limits, to make sure your magnesium is also within normal limits. You want to make sure your creatinine isn't rising too quickly, because you are diuresing these patients, and you could put them in a situation where they develop a pre-renal acute kidney injury. And so you want to monitor for that. And then, of course, as your patient is starting to improve clinically, if they're already on a home diuretic dose, you want to probably start that home diuretic orally to see how they respond to that, to see if they're able to tolerate that, to see if they don't rebound back into an exacerbation status. But overall, you want to optimize their home treatment therapy as well, right? And so the first way you would do that is by blocking that angiotensin II system. So you can start them on an angiotensin receptor neprilysin inhibitor, like sacubitril valsartan, or an angiotensin receptor blocker, like valsartan, or an ACE inhibitor, like lisinopril. And essentially, this is a drug that has been shown to improve mortality in this group of patients and also reduce the risk of hospitalization. You want to start them also on a beta blocker, like carvedilol or metoprolol succinate. Those two are popular agents to start these patients on. And again, this is a class of drugs that's been shown to improve mortality in this group of patients. A loop diuretic would be the third thing that you kind of want to start them on, just to make sure that you are getting that fluid off. And then some other agents that you can throw on there to fully optimize their home treatment is a mineralocorticoid receptor antagonist like spironolactone, and then an SGLT2 inhibitor like empagliflozin. These are also agents that have been shown to improve mortality risk in this group of patients as well. So sometimes you'll see patients on all 5 of these agents. Sometimes maybe 3 out of the 5 or 2 out of the 5. It all depends on how they respond to the medications, particularly their blood pressure, if it's able to withstand all of these medications. And then to really help you out with this, you probably want to get a cardiology consult and essentially have cardiology come and see them. Maybe cardiology can get them into a heart failure clinic where they can evaluate them and make sure they respond to their home regimen appropriately. And so that's pretty much how you would manage these patients. That's the broad strokes. New answer, MD, bringing you new answers.